Okay, let's get going. So it's a pleasure to be here today to introduce the newest addition to our CT fleet over at Hotel Dieu Hospital. I'm Charles Scott. I'm the medical director for CT at KHSC. And as you may know, we recently activated our newest scanner, which has been a monumental task in terms of time and effort since we started looking for it in about 2019, just before the pandemic. But it's finally up and going. Apparently, with the contributions of more than $1.6 million in community donor contributions. It's a big investment for the hospital and for the community and the city and the region in general. So we're very grateful for all that. I feel obliged to acknowledge the group effort that it took to get to this point. We had a committee of radiologists, technologists, and the hospital management involved in selecting, decommissioning the old scanner, replacing with a new scanner, construction projects. Too many people to name individually, but they know who you are, and it was a successful project in the end, as you'll soon find out. It was also a big undertaking to get ready to decommission the old scanner and to minimize the disruption to wait lists and prepare for the downtime, which was significant, and ramping back up and with minimal disruption, as I mentioned. And that also included the hospital managers, the technologists, and the clerical staff doing lots of extra work to get that done. So this scanner does everything that our old scanner could do better, but it's also a new era in that it is our really first foray into dual energy CT, also known as spectral CT, which we now actually have available at both of our hospital sites and all three scanners. This will be a bit of a gradual transition, I think, as we figure out how to use it. And ordering physicians don't really need to know about that or order it any differently. For the most part, the radiologist will decide during the protocoling process when dual energy is going to be used. But I should say that if any clinicians have any specific requests or thoughts about their areas where dual energy could come in useful, we're always open to discussions and looking for the best ways to use that technology. And that can be indicated on a requisition or discussed directly with the radiologists in your various subspecialty sections. So without further ado, I think I'll just give an overview of the agenda, and we have several different speakers. So we're going to first hear from Siew-Li Leaman, who's the program manager for CT at Imaging Services, as well as Dawne Marshall, our senior CT technologist, and Kelly Bradley, who's the charge technologist for CT. And they're going to talk us through the new suite and scheduling changes and recent waitlist developments. And then we'll hear from Arthur Voorpool, who is the product manager for CT from Canon, the vendor for this scanner, tell us all about the capabilities of the scanner. And Dr. Umer Nasir, who is one of our recent MSK radiologist hires and probably has the most experience in our department in the real world for use of dual energy CT. And then we'll see afterwards for a question and answer period. So we can move on ahead to the first topic.
All right, great. Thank you, Dr. Scott. So as you said, my name is Siew-Li, and I am the manager in imaging services aligned with CT at both the Hotel Dieu and KGH sites. We're going to talk briefly today about the services that we provide here day to day across KHSC. And I'm going to spend the first few minutes just talking about what I'm calling our road to replacement. And Dr. Scott already touched on this a little bit, but you know, I'll explain a little bit more. Here we have a lovely photo of our beautiful new CT scanner, you know, in the CT suite at Hotel Dieu, and it is up and running and scanning patients as we speak. So, you know, it looks really nice here, but like Dr. Scott said, it was a lot of work to get here. You know, I'll explain a little bit about why we needed to replace the scanner. Our old one that we had at Hotel Dieu was 15 years old. And for this type of equipment, that is very old. We were experiencing a lot of problems with it, needing repairs, and a lot of downtime with the scanner associated with having to do those repairs. And as well with that, we were fast approaching end of service life, meaning that the people that came and fixed the scanner, it would reach a point where they wouldn't do that anymore. So obviously we needed to replace it. And they had estimated for us 12 weeks of construction to get the room ready to install the new scanner. And that started on November 6th of 2023. As you know, some people here might know, we did run into some construction delays, and it did end up adding on about an extra month. So we had 4 months, over the past year where we only had 2 of our 3 scanners ready. We had to plan for that operationally, like Dr. Scott said, and we did this by front loading a lot of exams on all 3 of our scanners before the downtime, and then, increasing our outpatient capacity at KGH by 94% during downtime. So I do have to, send out some thanks to our amazing team that worked. It was the CT techs, the clerical staff, the radiologists, the radiology residents. Everyone really came together and worked really hard to keep up that volume. And we are very proud to be able to report that we were able to maintain our wait lists over that time. So before this whole project started, we had a wait list of about 4,500 recs. And after it was done, when the new scanner was up and running, we were again sitting at about that 4,500 level. So I think that is just tremendous. And I did want to highlight the efforts of the team and share with you that the team was also recognized with the KHSC Team Award in the care category for their efforts and hard work towards mitigating that impact and minimizing really that impact that the downtime had on our patient care. So if you just move to the next slide, please. Just sharing some, that one. Just sharing some other photos of, that had, we had taken in the suite. Obviously, lots of people were coming by to see the new scanner. There was a lot of excitement in Hotel Do Imaging over the past month. And then just excited to announce that we did resume full operations as of April 2nd. And next slide, please. So now I'm going to pass it off to some of our leads in this space to talk about what we provide, what services we provide, and what we really do day to day at both sites, and really highlight the differences between the services we provide at Hotel Do versus KGH. So I'll pass off to Dawn Marshall, who is our senior CT tech at Hotel Do, to let us know what we're doing day to day on the new scanner.
Yeah, hello everyone, and thank you, Siew-Li. So I'm just going to talk to you a little bit about the Hotel Do site patient population and what our typical week looks like. So as you can see, mainly our population consists of cancer care patients, including those from urology and other clinical services. This is probably about 75% of our patient population, and the other 25 consists of patients for diagnostic scans, CT colonography, follow-up respirology patients for treatment planning, or preoperative scans, especially for orthopedics. Now, our scan protocols that are site-specific for Hotel Do include CT colonography, outpatient cardiac and urography, as well as enterographies and some neurology scans for patients for sinuses, temporal bones, and circle of Willis angiograms. The technologists are on site from Monday to Friday, scanning from 7:30 a.m. to 8:30 p.m., after which we are here until 10 to support urgent care and day surgery patients. Weekends, one technologist is scanning from 11:30 a.m. to 7 p.m., and there are 17 scheduled patient exams during this time, with added patients from urgent care to fit in. We can go to the next slide, please. Thanks. So this is our typical template. It's we have our colonography patients scheduled Monday, Tuesday, and Thursdays. Urography is our urograms are every day except Wednesdays, when we do our cardiac scanning with support from one of the nurses from KGH IVR department. So we book 40 to 50 patients a day, depending on the day of the week, and depending if contrast enhancement is required or not. Additionally, every day we service the many clinics at Hotel Do, including urgent care, orthopedics, children outpatient clinic, endoscopy, ophthalmology, ENT, and respirology. These patients daily can consist from 5 to 10, and some days more, every day to that we schedule them into the template as fast as we can for their optimal care. So I just need to say, really, we're so happy, and I think I can talk on behalf of all of the techs at Hotel Do. We're so happy to be back up and running for the community with our new Canon Prism scanner. Thank you for your time.
All right. Yeah. Okay. Perfect. Thank you so much, Dawn. And it's exciting to kind of share that template just to show you what we do, every day. It's a lot of patients we're putting through, and the pace of work is quite quick. So I'm going to pass over to Kelly Bradley now, who is our charge CT tech that oversees both Hotel Do and KGH sites. And she's going to just talk about, the differences that we see at KGH, because obviously they serve our big inpatient population. So there you go, Kelly.
Hi, good afternoon, and thanks for joining us today to hear about our CT department at KHSC. KGH has 2 scanners, which we care for all inpatients and KGH emerged patients. Plus, we help support the outpatient population from cancer clinic, vascular clinic, family physicians. Given the ever-increasing demand for CT, we moved to a 24 service model in 2020. We scan outpatients from 8 to 8, Monday to Friday, and inpatients and emerged patients 24 hours, 365 days a year. We scan over 100 patients a day, approximately 75% of which are inpatients and emerge. Our scanners at KGH support the trauma and stroke teams of Southeastern Ontario, and we perform the lung biopsies here at our site in support of the LDAP program. The CT team worked very hard while Hotel Do was being installed, and it's great to have them back up and running. Thanks.
All right, thank you, Kelly, so much for outlining what we do at KGH, and really we really appreciate this opportunity to give you guys a little bit of insight into what we do and how hard we're working every day to keep up with our ever-growing wait list. So thank you very much, and I believe I'm passing off to Arthur from Canon now to talk about our new scanner, and not only the fact that we have a new scanner, which is great, but all of the new technology that is now accessible to us here at KHSC to provide better patient care.
Once again, I'm here with Suzette, our CT product specialist. I'm Arthur, the product manager, and I would like to take the opportunity for the next about 20 minutes to go with you through the new features of the brand new CT scanner at Hotel Do Hospital. Just a quick overview of Canon Medical. As you can see here, we have a wide portfolio of different medical devices, from ultrasound to MR, CT, of course, X-rays, and so forth. It's a bright future in healthcare with Canon, and we are very happy that since I believe it is 1989, Hotel Do Hospital, Kingston Health Science Centers are using our CT technology. As we all know, Canon is an imaging company, and we definitely bring you image quality that you can definitely depend on. Today, the topic, of course, is about CT. And well, the Aquilion One Prism CT scanner, which is the latest of Canon's CT portfolio, high-end CT scanner, and it has definitely a couple of interesting features. We go back to the year of 2007, when at that time Toshiba Medical Systems introduced the first wide area detector CT, which has never been seen before, because what is so unique is that the detector of the CT scanner itself covers 16 centimeters, and that has a lot of features that I will show you in the next presentation. So it started in 2007. Throughout the years, new developments came into the world, from Toshiba, now Canon, till in 2020, we introduced the Aquilion One Prism. Now, here is the first thing that it differentiates from other CT scanners that are currently in the market, and that is the 16 centimeter coverage per rotation of the gantry itself from the detector. It's here's an example of the coverage itself. It's 16 centimeters. So you can actually do an entire brain, an abdomen, liver, and a cardiac scan. And I will show you what are the benefits of this. Plus that we introduced with this machine, this CT scanner, the Aquilion One Prism, we also introduced the world of artificial intelligence, AI. And that is something that is quite unique, and it is a tremendous advantage for not only the radiologist in terms of image quality, but also definitely for the patient, because we can limit our radiation and lower our radiation dose significantly. So the scanner itself in Hotel Do has two scan modes. One is a helical scan mode, whereby the gantry detector, etc., rotates around the patient while the patient moves through the gantry itself. And then we have also the volume scan mode, whereby we just do one rotation covering the 16 centimeters of the detector. So it is a 320 detector system, and we create per rotation of the gantry 640 CT slices in a very high speed. The other thing is nice of this scanner is the lower position of the table itself. Makes it very easy for patients either in wheelchairs, elderly patients, pediatric patients, to enter and to lay down on the couch itself. It's only 32 centimeters from the floor. So let's have a look at some of the clinical applications that we offer with the Aquilion One Prism. First of all, I will have a quick look at the image quality itself. I mentioned it before. We introduced as Canon a unique feature, and that is called ACE. That stands for Advanced Intelligence Clear Image Quality Engine. So what we do is we use training material of CT scans in our factory to train certain algorithms to reconstruct the images for specific organs. It is for brain, it is for heart, cardiac scans, it is for MSK. And those algorithms are trained in the factory with an enormous amount of data, then implemented in the CT scanner. And finally, of course, it is validated, but then it is shipped out with the scanner itself. Here is an example of a very low radiation dose image. And you can see there is a tremendous amount of noise in this particular image. Not surprisingly, because the radiation dose is extremely low. But the effect is that you can't see any, let's say, anatomical structure. When we use now our AI reconstruction algorithm, you can see that there is a significant difference and hardly any noise in the image itself. Here's an example of the old days in CT. On the left-hand side, you see the filtered back projection that was used from the very beginning of the CT in 1975. And throughout the years, you can see on the right-hand side the same image, but a lot less radiation dose, first of all, and less noise in the image. So what we do is where we use, and you saw that before when Dawne explained the workloads, etc., in Hotel Do Hospital, one of the most important things is, I think, cardiac. And here is the advantage of this machine. By covering 16 centimeters. That means that we can actually do a heart scan in just one simple rotation. And the simple rotation is only 0.275, or a little over a quarter of a second. So that is a blink of an eye. The heart scan, the cardiac scan is acquired. With the help of this ACE, or the artificial intelligence reconstruction, we can lower the dose significantly. Here's an example to an ordinary CT scan, which uses the helical scan mode. In other words, that the patient is moved through the gantry on the right-hand side versus the one rotation. And it has an example here of a arrhythmia. The advantage here is that the CT scanner in Hotel Do is automatically monitoring the patient's heart rate during the scan. And if there is an arrhythmia, the scan is not performed, but it takes the next heartbeat, which is not possible with the scan mode on the right-hand side in terms of helical scanning. Here you see an example of a coronary artery with a stent in the center, very clear, defined, and again, this is a very low radiation dose for the patient, 0.4 millisieverts. Here's another example using our global illumination rendering, which is a special technique to create 3D images in more or less photorealistic. You can see this on the Vitria workstation, that is the separate workstation that is installed in Hotel Du Hospital, as well as KGH, to do any kind of post-processing of images that we have acquired. Here's another example what the cardiac stent shows in the standard reconstruction technique on the left-hand side versus the ACE reconstruction, and you see it is much better defined, the stent itself in the coronary arteries on the right-hand side than it is on the left-hand side, which is a little bit more blurred. And again, this is a sub-millisievert reconstruction and acquisition, which is a very, very low radiation dose to the patient. Also for MSK, it is a wonderful machine, and we take advantage again of that one rotation of the detector. Here you see an example of a patient for a wrist scan, whereby we can define what area we are scanning when the patient is comfortably sitting in on the back of the scanner itself. And these are some examples what you can acquire. You can do a dynamic scan for MSK, and that is not only for a wrist, but also for an elbow and a knee or ankle. So you can actually move, or the patient can actually move their joints while the scanner is acquiring it at the same time, which gives, of course, a much better idea for the orthopedic surgeon what is actually what could be wrong with the joint of the patient while a certain motion is in effect. Then another nice feature is for a technologist is this tech assist lateral slide. You can see on the right hand side, those are the old days where the technologist has to pull and push the patient itself in the right position, while the scanner at Hotel Du Hospital has this tech assist lateral slide, and it is just the push of a button where the patient moves lateral left or right. Then another feature on the scanner in Hotel Du is so-called sure subtraction. This is particularly for angiographic examinations. Here's an example of a carotid artery. And of course, the radiologists are interested in the vessels rather than all the bone around it. Now, this machine allows automatically to remove all the bone by itself, automatically, no interference of the technologist itself. And you can see here the carotid arteries, the vessels in the brain, and you can see it here in a different kind of setting, whereby this is called a maximum intensity. So our arteries, are depicted here very, very clearly. And this is all done automatically. Another interesting feature on the scanner itself is called CMER. It's single energy metal artifact reduction. Metal has always been the biggest enemy for CT scans because it doesn't allow the radiation or the protons to go through the metal, so resulting in a tremendous amount of artifacts. On the right hand side you see a bilateral hip prosthesis and the middle part of the image is just black, and that is because there is no proton going through the metal, resulting in these artifacts. Now, with the scanner, we have a method to reduce those artifacts significantly, if not all, as you can see in those examples. On the right upper versus the right lower, you can see what the result is of the single energy metal artifact reduction. Another advantage of the 16 centimeter coverage of the scanner in HOTEL-DO is, of course, for neuro. We can do a brain scan in just one simple rotation. Or we can see here what the effect is of this artificial intelligence. In the center, you can see the low contrast detectability of the brain versus the old way of reconstructing on the left-hand side. And this 72-year-old female with an acute cerebral infarction, this was proven by an MR scan in the very end. And also for a neuroscan for dynamic vascular triage. This is all done in less than 5 minutes. You can see on the advantage here that the one rotation is now spread out over a time frame of about 60 seconds with different acquisitions in between over those 60 seconds. So we capture actually the arterial phase, the venous phase, and the outflow of the contrast in the brain, whereby we can then reconstruct all these images. So we have the arterial phase, the venous phase. We have also the subtraction image on the right hand side here, as well as the perfusion image of the brain itself. All of this is done in less than 5 minutes, including the reconstruction of the images and the, of course, acquisition. Here's an example of the reconstruction of the brain with a very clear acute stroke of the left MCA, the middle cerebral artery, which is clearly depicted here in this reconstruction. Then we have on the scanner in HOTEL-DO also a new feature, and that is called the spectral imaging. And the next speaker will talk a little bit more about spectral imaging and dual energy. I will show you just quickly what it actually does. With this new scanner, we have introduced a rapid kV switching. So the system itself rapidly, and I'm talking about less than milliseconds, between a low kilovolts and a high kilovolt, because those have different energy levels. And we do this during the acquisition, in this case. And we then reconstruct the images with the DCNN, the deep convolution neural network, what we use for the regular CT reconstructions as well, whereby the system is able to differentiate the high kV and the low kV very, very precisely. And that is what we actually want to see with spectral or dual energy. The word, it says dual energy. We have dual energies that we are using for these specific acquisitions. Here's an example of what it can bring. In the center, you can see the carotid arteries on a lower energy level on the left. In this case, it's a 55 keV, kilo electron volt, versus the 90 kilo electron volt. And what is extremely nice here is that because of the absorption of contrast that was injected to the patient, iodine has a high absorption level at around 55, but not so much about 90. So you can see the difference, whereby the occlusion in the carotid artery is more clear with a higher energy level than it is on the 55 on the lower energy level. Here's another example of a liver scan, whereby we define the uptake from iodine in the liver to define if it is a malignant or a benign lesion in the liver itself. You can see here that the blue line is a high uptake of iodine in the liver, whereby the regions of interest is in the liver itself, and in the rest of the tissue of the liver, it's yellow, and there is hardly any iodine uptake there to be seen. So this is a very great feature of this machine to do these spectral or dual energy, and then afterwards we can reconstruct and we can analyze these images on the Vitria workstation. Last but not least, and that's unique in this scanner in Hotel Do, is Canon introduced the silver beam filtration. And silver beam filtration is a special method to lower the radiation dose to an extraordinary low level, which is of course beneficial for the patient, but we don't see a degradation in the image quality itself. Here is an example of an effective radiation dose of 0.3 millisievert, and now we are talking about the level of a regular X-ray of the chest, AP or lateral X-ray of the chest, but now with a CT scan that creates roughly the same radiation dose, but it gives, of course, a lot more information to the radiologist than just an ordinary X-ray, AP or lateral. So this is a very nice feature on the Aquilion 1 Prism installed at Hotel Do for future planning of lung screening, or in general the radiation of lowering the radiation dose for chest CTs. Here's an example of what it used to be on a conventional CT. On the left-hand side, it's 2.57 millisieverts, and using this silver beam, you see there is no degradation in image quality. However, it's only 0.45, so that's about 60-70% of radiation savings to the patient. The scanner itself is taken care of by our wonderful CT team. Some of you definitely know Kristen, Suzette, and we have Seema in our team from Ottawa, and Christina. She was there in Hotel Do as well for the Go Live training. So yeah, I think that Hotel Do Hospital is definitely in good hands with such a wonderful team, and that is what I wanted to share with you now in regards to our new CT scanner at Hotel Do Hospital. Are there any questions?
I think, Arthur, thanks very much. I think we'll hold questions for the very end, and we'll go right into Dr. Nasir's talk right now, and then we'll see you after that.
Hey, wonderful.
Charles, can you hear me?
Yep, sounds good.
Brilliant. So my name is Dr. Umer Nasir. I'm one of the musculoskeletal radiologists. So I'm going to focus just on the spectral bit of our new machine. So it's your choice whether you want to call it a spectral CT, multi-energy CT, or DECT. They all mean the same, but it's just the difference of words. So the cases that I'm going to share during this presentation are the ones which I encountered during my training at UBC, and some of them are from the literature. So during the course of this talk, we're going to be talking about the basic principles of the CT, the clinical applications, its indications in various organ systems like musculoskeletal, chest, head and neck, abdomen, and pelvis. So basically, to put it in a very simple way, what is spectral imaging? So if you see this rounded, the circle around your image, that means this is a spectral image you're dealing with. So with a human eye, we cannot actually differentiate between these two density. It's just the our knowledge of anatomy, which tells us that there is contrast pooling in the renal pelvis, and this is bone. But can our machine differentiate between these two densities? Yes, with DCT, if these two densities are closer together, our scanners can tell us what is contrast and what is the bone. So what does it mean? It means that at a certain kV level, say at 100, where these two line graphs actually intersect, we won't be able to tell the difference in the Hounsfield unit at this kV. What if you go to the lower kV level, as Arthur also explained in his presentation, that there would be different Hounsfield units? So that tells us that the Hounsfield units or attenuation is energy dependent. As you can see from these two images, that Hounsfield units are changing. So that's not a constant thing. So is this a new finding? No, it was known before, and it's just that now we are just putting it in use. And all you need to remember from this slide is that attenuation is energy dependent. Now, what does that mean? Like, if you look at the low part of the spectrum, you would see that the high atomic number material like bone and iodine are more accentuated, as you can see the iodine and bone in a much better way here. And at the lower end, there would be more less accentuated. So regarding the dose, if any of the clinicians are worried about that this is a spectral CT, is multi-switching or dual energy, are our patients going to get more dose? No, it can be dose neutral, and there are various studies to support that it can actually give the same results at a lower dose. Now, what are the clinical application? I'll quickly, touch upon them. There are different applications that you can use in your spectral imaging. So in MSK, the ones you can use is gout. Like in this patient, you can see there are no pathognomic peri-articular erosions, and even on the right side, you can hardly see any high density material around the joint space. But with the use of spectral imaging, we can actually highlight the monosodium urate deposition, and it can even quantify it for you. So subclinical cases or patients who are on treatment, it can tell you how well they're doing over the period of time. Then there's a marrow edema application. It's an everyday conundrum, right? When we are like, all right, is this a real fracture or is just a prior injury? And then generally now we use MRI to kind of get an answer for that. But with the DCT, you can skip that step because DCT can tell you or show you the marrow edema around that bone. And that can, and here in this example, you can see it's fairly, similar to the marrow edema pattern on MRI. Then there is an application which is called virtual non-calcium application. Again, it can accentuate edema around the SI joints. And with the collagen application, basically, it can, anything which is more denser than the regular soft tissue, like our disc material and our tendons, it can highlight that, as well as in these cases, you can see the disc herniation looks fairly similar to the MRI. And if you do a CT for the periphery, now if you want to comment about the tendinous entrapment, you can do it on the CT, no need for MRI. In patients who cannot undergo MRI and you do a CT arthrogram, it can surely accentuate on the iodine overlay map any kind of tears in the labrum. And this is exactly what we talked initially, that, if you want to differentiate between the contrast and the bone, in the cases of complex pelvic trauma, if you use your iodine overlay map, you can tell what is contrast and what is bone. And this was briefly touched upon by Arthur as well, that, with the spectral imaging, you're dealing with different KVs, and, you can actually play around with them where the metal artifact is the least, right? And then it kind of, shows this metallic fracture in a much better way. So shifting gears to chest, one of the most common and talked about is that if you look at the perfusion map first for your PE study and you see this wedge-shaped defect there, and you can actually go in retrospect and look at your long parenchymal images and your vascular images and see that there could be a clot sitting there. So that can actually reduce your time. The other thing, which is really studied in this domain is the use in CTEPH. And there's a lot of literature which kind of tell us that the DCT is at least equivalent to the VQ scan in diagnosing CTEPH, and the scoring system is fairly comparable to the invasive measurement of pressures. With, as you can see in this study, the raw values are fairly substantial. And then, if we use the monoenergetic images, I know we had this conversation with Dr. Islam as well, that yes, we can now use the lower dose of contrast and still give very good images on a lower KV, as here you can see the iodine and calcium is fairly accentuated, and we can actually see it in a better way. So another use is in the cardiac domain is where we run into this question whether it is a circulatory stasis or it's a true thrombus living in the left atrial appendage. So here, if you can see, measure, as Arthur also mentioned, if we measure the density of the iodine, the thrombus should be lower. The other use is in the beam hardening. So generally, when you're dealing with the monoenergetic beam, their beam hardening is far less. So that can be used. And so this is fairly under, this is under research. And if somebody is interested, they can actually work more on it. So, you can use the spectral imaging to actually characterize and even quantify the coronary arterial plaques. Then, with the perfusion images, they can actually depict what is true ischemia in the cardiac wall. So from the neuro point of view, the most commonly used application is a patient has underwent vascular treatment, whether there's contrast staining or true hemorrhage. All you have to do is go to your virtual non-contrast images. It will remove all the contrast from there. And, you can be fairly confident saying that this is contrast staining. And then you have your iodine overlay maps, which kind of increase your confidence. So now if you ask yourself whether it's just a tumor sitting there or a large bleed, so with your contrast or iodine overlay maps, you can see this enhancing tumors sitting along with the surrounding hemorrhage. So coming to a few uses in the abdominal cavity, the first thing is that urologists get very excited about it, where you can now tell what is the urinary calculus made up of. Because if it is uric acid, which you can see in this example, you can actually alter the management course of the patient. The other use is that bowel ischemia. Again, by the use of iodine overlay, you can see that now it kind of increases your diagnostic confidence and accuracy of telling that this bowel wall is not enhancing, as you can see from the perioperative images, that this is an ischemic bowel there. The other application that can be useful is in the gallstone application. So we call this back in the day a case of fallen gallstone. This patient had lymphoma as well, and came to emerge with this mass, and we were a bit in a conundrum whether this is actually the lymphoma recurrence or what is it. But when we were actually doing a dual antigen analysis, and on the gallstone application, it did show the color coding of a gallstone. And then when we went back, looked into the history, there was a remote history of cholecystectomy, where unfortunately the gallbladder ruptured perioperatively, and this stone actually gave some phlegmonous tissue, so it wasn't disease, which was later proven on biopsy as well. So again, it was going to save your time, save your resources if you use the gallbladder application, because it's again an everyday scenario where you run into isodense calculi on the CT. Then what we do now is we look into the ultrasound and see whether there are any calculi there. But with the gallstone protocol, you can just a click away, you can appreciate those stones and then process it accordingly. And that's fairly it. Thank you for joining us and welcoming a new scanner. And if you have any questions, please go ahead.
Thanks, Omar. That was a great overview. As an abdominal imager, I'm quite excited about finally being able to see non-calcified gallstones on CT, and maybe eventually not requiring that ultrasound after a CT suggests there's gallbladder pathology if we can visualize these gallstones with dual energy CT. And thanks to everyone else for their contributions, especially our invited guest from Canon, Arthur. We have some time left for questions. If anyone has any burning questions about anything that came up today, I'd just like to remind you that this webinar was recorded and will be available somehow. I assume Pam Moore would probably know exactly how to access it. So spread the word if anyone has any questions that you know in your circle about the dual energy CT and new scanner. We'll have this available somehow afterwards electronically. So is there any comments or questions in the audience? Or in the chat? Oh, Dr. Zaza, go ahead.
Hi, thank you so much for this presentation. Very informative, and appreciate all the great work, that will probably enhance many of the capabilities for our patients. And thank you for inviting us to this webinar, and I'm sure you'll make it available as well. But if there's anything that helps for us to spread the word about any new features, or how even that might change how we order or request any particular scan. I know most of the time, it's left up to your expertise to decide, which protocol, but sometimes actually for us, understanding just what is out there might be helpful when we request a particular scan or state the indication. And I think I'll stop at that. There was another question I had about the scheduling and backlog, but I think we can talk about that offline unless you feel it's relevant. Thank you.
Sure, that's a good point. I'll just reiterate, I think the most important thing is the indication and good quality clinical information on the requisition. This is going to be a work in progress, figuring out when to use it, how to use it. You do have to decide prospectively when you're doing a scan, whether it's dual energy or not, and you can't retrospectively decide that. So based on the indications and what we develop as our, consistent use cases for dual energy, I think that'll fall into place, but always up for discussion. If you or any other clinicians have an idea about how this could impact your care and your practice, I think now is the time when we have great support from Canon. We're building protocols, and we're, for the most part, interested in rolling this out. And interest from people like you will help drive that, I think. So, but in general, you don't really need to worry about whether or not it's going to be dual energy, based on other than to give us the best clinical information. If you have a specific reason to use dual energy, sure, bring that up. That can be on the requisition. That can be with direct discussions with the radiologists in the section that's relevant.
Thank you.
So I haven't seen another hand or anything in the chat. So if anyone has anything, please speak up. Otherwise,
Charles,
about time, and Omar's here.
Yeah, Charles, maybe I can ask a question or two. So can you comment, or any one of the speakers comment on the reduction in contrast usage? Because that's really important for our patients. As what sort of % of contrast reduction are we hoping for or expecting with the new scanner? Well, I'll ask my second question after that. Thanks.
Yeah, I'd like to hear over Nasir and maybe Arthur's opinions on that. I mean, for now it's theoretical, but in theory, you should be able to reduce the contrast dose, and especially useful in angiography patients with impaired renal function. We don't have a lot of experience yet on the ground, but I'll throw it to the other two I mentioned if they have any more expert insight into that question.
All right, I can go first. So Umer, as I kind of shared a couple of papers as well, that it is actually true that you can have good quality images even at a lower KV and a lower contrast volume. And so most of the studies which are there were done in the cardiothoracic region. And yes, it's possible. And then your question, next question was how much? They do claim that it can be up to half of the contrast we were using initially for the cardiac imaging. And then the other thing is that generally, from our clinical practice, that if you're on call at times, we do the PE study and we're not very happy with the amount of contrast that's gone there, or with the phase is not as good. So that can be actually that can actually improve your diagnostic confidence if you have the perfusion maps with you, because then you don't need to have that perfect dose and the perfect dose of contrast or the perfect phase. It can still be helpful in that case. I hope that answers your question.
Yes, thank you. I think a couple of weeks ago with Dawne over at the DO, for the neuro, we reduced our CT angiographic dose by a significant amount, right, Dawne? It went from 70 to 60 cc's per case, so more than 10%, if I'm remembering that correctly. And without any loss of image quality and angiographic staining. So that was really nice to see with the new scanner.
That's correct. We reduced by, I think, 20 cc's.
20 cc's.
And also for our cardiac scanning, we've reduced 20 cc's.
So that's great for the patients, and it's great for the bottom line for the hospital as well. If you're saving 10 to 20% on every patient, over a year, that's thousands and thousands of patients who we're saving contrast for. So reducing the risk of nephrogenic toxicity, as well as the finance department loves us then, or likes us a little bit better.
Yeah, I was just talking with Suzette here, Omar, that we see indeed with these new scanners and acquisition methods that we are using up to about a 30% reduction compared to, let's say, before. And that reflects about 20 mils. Yeah, what Dawne just said.
Thank you. One last question, quick question I have, if I can, Charles. Efficiency, does the new scanner improve efficiency? Maybe Dawne, you can answer this better. Do you think long term, I know we're getting up and started right now, so a lot of takes a bit longer per case, but after some time, do you think there will be increased efficiency with the new scanner compared to our previous scanner?
Well, again, it does have some nice features that are sort of technologist friendly and should improve throughput. But Dawne, Siew-Li, what do you think about individual patient times and template load for the new scanner compared with the old scanner?
So I believe Siew-Li just had to go to another meeting, but I can say as soon as we find our efficiencies, because some times we will have more post-processing to do for things that are new now, but we're going to find our efficiencies. And I do believe down the road, and I'm going to say 3 to 6 months, we'll definitely, I think, be able to increase our patient load. I'm not going to say by 10, I'm not going to say by 5 patients a day, but I think we will be able to do more.
Yeah, I remember, Dawne, when I was in the Hotel Do, I think it was in the second week of operation, that the speed, for example, the speed of reconstruction, which is about 3 times faster than you were used to with the older machine, that will definitely contribute to some more efficiency as well. I mean, you don't have to wait that long before your final exam is reconstructed. Huh?
That's absolutely true. It's
amazing. I remember you were surprised that you asked you asked Alex, "Oh, how many images are there still in the queue?" And they said, "No, none. It's already done." Oh, so that's it's definitely contributing to some more efficient work for sure.
Absolutely, totally agree, Arthur.
Well, that's true, and that's important for turnaround time, and how soon the images pop up for us to report an emerge case. Should be something noticeable by the clinicians as well.
Yeah.
Okay, well, thanks again to everybody. Thanks for listening, and stay tuned as we start to use this resource to full effect. That's it for us today.